Hello everyone, very good evening to all of you again. Myself Saurav Saha, I am Head of Marketing from Samarth Oncology, and today we are here together again in the same platform, and we are every time very happy to get all our delegates and faculties in the same platform. So today we are here at this Zoom platform to talk on NET. So neuroendocrine tumor is one of the tumor which is not well spoken and well discussed actually as of now. So we are here to discuss the second series of the event, which is known as Talk on Net. We used to organize another set of webinar which is known as Osmosis, which is actually taking care of the other disease areas like prostate cancer. So now here we are talking about NET. We have with us, extremely happy to share the name, Dr. Suresh Babu, who is HOD, Department of Medical Oncology, Kidwai Institute of Oncology, Bangalore. So when you are talking about Dr. Suresh Babu, he is well known to all of us. He's not only is famous and well renowned in South India as well as in the entire India. Dr. Suresh Babu's name is well known to each and every fraternities as well as in oncology industry. So with that, Dr. Suresh Babu, I welcome you for this meeting, and to direct you are our director, and I request Dr. Suresh Babu to start on this meeting. And at the same time, I also request Anjana, who is our part of medical team, and I request you kindly run through the agenda before the start of the event, and you can start with this meeting. Thank you.
Thank you so much, Saurav. Okay, good evening, everyone. I am Anjana Yadav from the medical team of Samarth Life Sciences. I again welcome all the speakers, panelists, delegates, and Team Samarth. On behalf of the organization, I am delighted to welcome you all for today's webinar that we refer to as Talk on Net. Now, this is a scientific initiative which is bought by our oncology division, that is OnQuest. In this activity, Samarth as an organization aims to provide a scientific platform to discuss on various topics which are related to, especially when we are talking on Talk on Net, it is specifically on net. We therefore believe that it is not just a scientific platform but also a powerful metaphor for knowledge dissemination, and this process of knowledge updation is very crucial, especially in the ever evolving field of oncology. The focal point of today's discussion, as already said by Mr. Saurav Saha, the topic for today's discussion is recent clinical updates in the treatment of gastroenteropancreatic neuroendocrine tumors, that is GEPNET. We are fortunate to have with us esteemed experts who will share their insights and experiences on this topic. Before we start, let me give you a brief about our company profile. So, Samarth Life Sciences is an innovative life science company that researches, develops, manufactures, and markets a broad range of life saving critical care products and other drugs. With our vision to emerge as an innovative premier healthcare company, we are committed to deliver healthcare products with the highest level of operational excellence. Now, since the inception in the year 1963 by Mr. Gunwant Lal Shah, Samarth Life Sciences has been a prominent player in the pharmaceutical industry. Samarth Life Sciences operates through around 14 therapeutic specialty division, each focusing on specific area of healthcare to provide targeted solutions and expertise across a broad spectrum of medical conditions. OnQuest is one of the divisions that caters the oncology specialty. We export over 250 products in over 70 countries, demonstrating our global presence and commitment to serve the diverse market. We are also proud to share that Samarth Life Sciences has received significant accolades and recognition, reflecting its excellence and influence in the healthcare sector. With this short brief, we would like to initiate the scientific program. For this, I would again like to introduce our program director and speaker for today's session, for today's Talk on Net, that is Dr. Suresh Babu, MC Sir. He is an HOD of Department of Medical Oncology, Kidwai Memorial Institute of Oncology, Bangalore. He will enlighten us by delivering a talk on the recent clinical updates in the treatment of gastroenteropancreatic neuroendocrine tumors, that is GEPNETs. Over to you, sir.
Thank you, Anjana. I think I will you start sharing my screen. My screen is visible to all of you.
Yes, sir. Yes, sir.
I think the neuroendocrine tumors we know is that is something which we most of the time neglect about the neuroendocrine tumors. I think the thing we are going to see in this presentation is that what is the background of neuroendocrine tumors, how are they classified, how are they diagnosed, how are we going to manage, and is there any recent update in the management of neuroendocrine tumors? So neuroendocrine tumors are not well known a decade before because the pathological and the way to look into it was very different. And now we know that the neuroendocrine tumors are quite common in the world today. The common sites of neuroendocrine tumors are GI tract, lungs, and pancreas. Why neuroendocrine tumors are not so well noticed is because we traditionally believe that neuroendocrine tumors are not malignant. We believe that neuroendocrine tumors are more, which is not true. The truth is that neuroendocrines are, all of them are potentially malignant. Anytime they can become very aggressive, and very often they present in advanced disease. The second myth is that neuroendocrine tumor is a very rare tumor, so why should we know about it? If you see the statistics data, in the GI tract, after the colon and rectum, neuroendocrine tumor is the second most common. In fact, it is more than the combined gastric and pancreatic cancers together. So neuroendocrine tumor cannot be taken as a rare tumor, and neuroendocrine tumor cannot be neglected as a benign disease. So it is malignant. It is also now becoming more common. So if you see the epidemiological data, the incidence of neuroendocrine tumor has been rising since 1973. But that may not be related to only to the incidence. That may be because that we are starting to look into the neuroendocrine tumors more in recent times, and also the diagnostic methods and the pathological clarification regarding the diagnosis of the neuroendocrine tumors have increased in the recent days. As I was telling you, neuroendocrine tumors are most often diagnosed late. That is basically because most of the neuroendocrine tumors initially are very asymptomatic. They become symptomatic only when they are advanced disease. So that's why the neuroendocrine tumors are diagnosed in a late stage. Why it matters that why neuroendocrine tumors we have to detect it early is because if you see the survival data, like any other cancer, if they're localized and regional, the chance of survival is more better when they become distant metastasis. So when they become metastatic, then the chance of survival falls into about average of 33 minutes, which is only very less compared to localized disease, which is almost 223 months. So as far as the location of the neuroendocrine tumor is concerned, as I was telling you, GIT is the most common site. Rectum, jejunum, and pancreas and stomach run the top four, followed by lung being the next most common site. About 15% of the neuroendocrine tumors remain as a unknown site of origin. So if you see the Indian data is quite conflicting. There were two studies. One study said that stomach is the most common, but our other studies said the pancreas is more common. However, we can look into the data now. More data is required where we can see Indians which the neuroendocrine tumor site is most common. So this is the change of classification happened in the neuroendocrine tumors. As you see, till 2010, neuroendocrine tumor recognition or the diagnosis with pathology was a little cumbersome. But in 2010, the neuroendocrine tumor were graded grade 1, grade 2, grade 3, and neuroendocrine carcinoma came. Of course, there was the MANAC, the mixed adrenoneuroendocrine carcinoma was introduced in 2010. In 2019, it was more refined. They brought the small cell type and large cell type in neuroendocrine carcinoma. Of course, there was the other sixth type called as minion. So all these classification had three things. One is the grade, mitotic area, and K67. It's very important that we recognize it belongs to which grade or which type, because the treatment basically depends on all those things. And the classification of neuroendocrine tumor is very, very important because it determines the management of the same. Presentation is highly variable. Most of them may remain asymptomatic for years. they become symptomatic only because of the bulkiness of the disease or the peptide hormone which they secrete. So most of the time, what happens is that in a metastatic gastrointestinal neuroendocrine tumor, they secrete the vasoactive substances. Most of the time, they secrete when they become metastasis to the liver. So they produce a carcinoid syndrome-like symptoms like flushing, wheezing, diarrhea, and also may lead into right-sided heart failure. So as I was telling you, when they become metastatic to liver, especially in mid-cut, they try to create a symptom like carcinoid syndrome. But whereas in extraintestinal neuroendocrine tumors, carcinoid syndromes can become manifest even without the liver metastasis. So there is some differences in symptomatic and asymptomatic. Asymptomatic neuroendocrine tumors which tend to be more aggressive compared to that of the symptomatic. And symptomatic seems to be slow growing. The morbidity in symptomatic is morely because of hormone secretion, whereas in asymptomatic it is because of the tumor bulk. And asymptomatic, as I was telling you, there are no symptoms associated with hormone production, whereas in symptomatic is mostly because of the hormone productions. There are various syndromes, subtypes associated with neuroendocrine tumors, pancreatic, like insulinoma, gastrinoma, PIPMR, glucogonoma. So they come to you with the very variety of symptoms. Insulinoma may come to you with weight gain and hypoglycemia. VIPMR can come to with acidosis. So ultimately, it depends what type of subtype of pancreatic neuroendocrine tumor is there, which will produce to that of the symptoms accordingly. Another thing with the patients, the neuroendocrine tumor which is not associated with clinical syndrome are majorly because of the presence of bulkiness of disease. They may present abdominal pain. There may be, intermittent bowel obstruction. There could be a ischemia leading to bowel fibrosis. Hydronephrosis can be there because of the bulkiness. And retroperitoneal lymph node enlargement can also produce abdominal pain as far as the asymptomatic neuroendocrine tumors in pancreas is concerned. So when you should have suspicion of neuroendocrine tumor, is it first you take out from mind that neuroendocrine tumor is not a rare disease. It's the most common, it's one of the commonest diseases nowadays. Another thing is that if you have a carcinoid-like features which is unrelated to time, day, or anything, then it could be a symptom of neuroendocrine tumor underlying. Chromogranin A could be one of the markers which can be elevated in neuroendocrine tumors. Of course, it has its own limitation, but if you do see a patient with these symptoms and having a chromogranin level elevated, you must strongly suspect patient is suffering from neuroendocrine tumors. Diagnostic procedures, of course, examination and histopathology. We can do biochemical markers to serum, tissue, or venereally. This thing, hormonal analysis can be done. Radiology can aid us in diagnosis. Somatostatin receptor scintigraphy is not done so much in our country. Of course, PET we do. We do DOTA PET and FDG PET now we are doing in grade 2 or more because there is a discussion that grade 2 or more can have both combination of the FDG sensitive and DOTA PET. So in grade 1, we usually confine us to DOTA PET. In grade 2 onwards, we do FDG PET in combination with DOTA PET. The biomarkers is something that we look into. Chromogranin A and HIA and NSD are something which are non-specific. This is the limitation of these biomarkers. Sensitivity and specificity have high variability. We cannot definitely rely on them as far as the diagnosis is concerned. Of course, NET test is one of the new thing which has come. If you see the sensitivity and specificity of NET is almost more than 90%. NET seems to have better sensitivity and specificity as far as the diagnosis of neuroendocrine tumor is concerned. As I was telling you, chromogranin A can be elevated in other conditions also. It has also got variation in proton pump inhibitors that can mislead the diagnosis with the elevation of the chromogranin A. So there is a lot of factors which are confounding as far as the chromogranin A elevation is concerned. So NET test is something which I was telling you with more specificity and sensitivity. It is a PCR-based test which have some 51 transcript signature into that. As I was telling you, sensitivity and specificity of this test is almost more than 90%, which can be a very good test in diagnosis of neuroendocrine tumors. If you see the correct prediction of neuroendocrine tumors with NET test, irrespective of the site, it seems to be a better test as far as the diagnosis of the neuroendocrine tumor is concerned. So diagnostic strategy, if you suspect a neuroendocrine tumor, if they have classical symptoms, you do a markers. So if that is positive, then you do a scanning. Based on that, you can do other investigation of whether it's coming from the stomach, small bowel, or colon. Based on that, you can do colonoscopy or colposcopy, any capsule endoscopy or anything. If there is no, markers elevated, you can do a provocations test. If they are negative, then you can follow up with specific symptoms and see. If they are positive, then you can do imaging, and based on the site, you can do the endoscopy or the endoscopy based on whatever symptoms there. The general treatment goal for neuroendocrine tumor is always cure. So it means if it is localized, you always have to do a surgery and try to cure the neuroendocrine tumors. In advanced neuroendocrine tumors, of course, you see if the surgery is feasible. That's the best option because that's the only option which you can cure. And pharmacological treatment is an option if the patient is not fit candidate for surgery. So debulking treatment like liver dearterization, radiofrequency ablation, liver transplant, medical treatment like somatostatin analogs. There are small molecules like everolimus, bevacizumab can be used. Of course, nuclear medicine based treatment like lutetium are also there. Symptomatic treatment like fluorouracil and all can be also the treatment option based on the symptoms. Localized disease or oligometastatic disease, as I was telling you, surgery is the role. If you can resect, better completely resect it. There is no standard role for debulking surgery in extensive liver metastasis. The patient is having extensive liver metastasis, there is no role of surgery. If the primary is very bulky and causing some symptomatic or obstruction, to relieve the symptoms, you can do surgery. If the liver metastases are resectable along with the primary, then curative resection can be done. Radiofrequency ablation in liver predominant disease can be used as an adjuvant to surgery. Tears and tear are more of a symptomatic relief than in a curative intent in environmental tumor. It's more often used in a palliative setting. So treatment, if surgery is feasible, then better to do surgery. If surgery is not feasible in grade 1, somatostatin receptor analogs can be used as medical treatment. The second line options of the nuclear medicine like treatment, peptide receptor based treatment are there. In grade 2, everolimus sunitinib will come into picture. Grade 3, temozolomide in combination with capecitabine can be used. Of course, in neuroendocrine carcinoma, it's most often with chemotherapy than targeted therapy or nuclear-based medicine-based treatments. If you compare it, look into the gastrointestinal neuroendocrine tumor, particularly surgery debulking is possible, kindly do the surgery. If there is any local symptoms because in unresectable disease, then you can try to do resection of primary tumor only to relieve the obstructive or any other symptoms. In unresectable low burden tumor, there could be an option of observation and also using the octreotide or lanreotide. In unresectable clinically significant tumor, you can go for the long-acting octreotide or other alternative first-line treatments which we discussed in the past. Somatostatin analogs, there are two analogs which are used. One is octreotide, another one is lanreotide. Both are depot or long-acting. Both have similar efficacy. They are continued till the progression. There are some studies to say dose escalation if there is a progression of these drugs. However, these are not mentioned in the guidelines. Beyond progression, you can continue only if the patient is somatostatin receptor positive and functional tumors. In non-functional tumors, they are not going to be of no use. So octreotide may have an anti-tumor effect, direct anti-tumor effect by acting on the receptor. It can also have an anti-tumor effect by inhibition of cytokine secretion, and it also have an anti-tumor effect by inhibition of growth factor synthesis. So PROMIT study is one of the first study which proved the role of octreotide in neuroendocrine tumors. Here, in this study, patients with mutated neuroendocrine tumor, especially well differentiated grade 1 or grade 2 are included in the study. Octreotide was given in one arm, other arm at placebo. The treatment was continued until the documented progression was there. Primary endpoint was the PFS, the secondary endpoint was objective response rate. As you can see that the PROMIT study did prove that octreotide as a significant treatment option in the neuroendocrine tumors which are low grade or intermediate grade compared to the placebo. The PFS was quite significant. You could see the other ratio of almost 0.34 there was 66% chance of reduction in risk of tumor progression, which was quite significant. Of course, the somatostatin analogs do come with adverse effects. Number one, the nausea. There could be abdominal cramps. There could be slight impairment of the glucose tolerance, symptomatic gallstones, hypocalcemia, bradycardia, acute pancreatitis. So when you are giving somatostatin analogs, always consider supplementing with the pancreatic enzymes. It will give some symptomatic relief as far as that, adverse effects of blood is concerned. So benefit and challenges, as I was telling you, it will definitely give benefit from carcinoid like symptoms, features, and the toxicity is very low and long-term efficacy is proven. It is convenient because it is given once every week. Limitation, it may not work so in a high tumor burden. There could be tachyphylaxis. Insulinumab can create a paradoxical effects, and there is no value if the patient is under supplement neuroendocrine tumor. In a coronary artery disease, something which should be looked into if the patient is on neuroendocrine somatostatin receptor. What if there is a progression of these drugs? There are many options which are available. One of the option is using the everolimus, especially in the pancreatic everolimus is tried in the first line option. Everolimus can also be tried with the second line with other TKS. Of course, peptide receptor nuclear therapy, which is coming very, I think in practice, most of us, if the patient is progressing on the first line of SSRTs, then we are going for the nuclear medicine-based therapy. Local immunotherapy like liver-directed therapy, radiotherapy can also be given in oligometastatic disease for the symptomatic disease. mTOR and TKS everolimus, as I was telling you in Radiant 2 trial, it was more often used. It was combined with long-acting activated. It did increase the progression-free survival, but there was no difference in overall survival. Probably in a patient with asymptomatic, low volume disease with functional tumors, because then everolimus combination with the long-acting activated may be of useful. But remember that the functional tumors will benefit if you give long-acting activated. Combining them with the everolimus could be helpful in this. Multikinase inhibitor like sunitinib, pazopanib, sorafenib, other drugs which are used. So this is the Radiant study where the everolimus was particularly trialed in the pancreatic neuroendocrine tumor. Everolimus 10 mg per day was compared to that of the placebo treatment. Primary endpoint was progression-free survival. Secondary endpoint was overall survival. The treatment was continued until the progression. As you can see, the everolimus did show clear-cut benefit compared to placebo in the pancreatic neuroendocrine tumors. Of course, there were some of the side effects were discussed as far as the everolimus is concerned. The mucositis and all those things were discussed. And also there were reports of lung toxicity. So everolimus giving 10 mg per day is practically challenging in a patient with neuroendocrine tumor because it not the side effects. Advantages of the actrotide or all those is that actrotide can be combined with any drugs because actrotide per se will carry a very less side effect. So there were some strategies to combine the actrotide. So this is the Radiant 2 study which tried to look into the neuroendocrine tumors of intermediate grade, where they combined everolimus with actrotide in compared to that of the actrotide alone. The crossover was permitted. Primary endpoint was progression-free survival. Secondary endpoint was the tumor response, overall survival, and time of capacity. As you can see, there was a clear-cut progression-free survival benefit, but as I was telling you, there was no overall survival benefit in this study. So there could be some group of patients where you want to combine everolimus with actrotide and try to get a benefit out of it. However, there was no any overall survival benefit in this. Another one was the sunitinib, its comparison with the placebo in advanced neuroendocrine tumor pancreatic. Sunitinib was given 37.5 mg continuously compared to the placebo. Primary endpoint again was progression-free survival. The secondary endpoint was overall survival and time to progression. So if you see the progression-free survival data, I think the progression-free survival did show a benefit in favor of sunitinib compared to that of the placebo. But however, the overall survival data was not so distinct. One of the things said was that almost more than 35% of the people crossed over from the placebo arm to sunitinib. However, the sunitinib still remains as a standard of treatment. You can, try sunitinib. Sunitinib did give a significant progression-free survival benefit. In this trial, overall survival benefit was not seen because of the crossover of the patients. As far as the chemotherapy is concerned, we know neuroendocrine tumor, especially in low-grade chemotherapy, is not a good option. If you see the objective response rates are very low. So in a low-grade neuroendocrine tumors, chemotherapy hardly works. Of course, it works in a carcinoma patients. So this is what I was trying to tell you. Objective response rate is less than 20% if you use chemotherapy in neuroendocrine tumors, especially in grade 1 and grade 2. So the grade 3 or carcinoma neuroendocrine tumors, if you see the response is very good, almost more than 60%. So if you have a high grade or neuroendocrine carcinomas, then chemotherapy could be an option. Temozolomide in combination with capecitabine is again one of the new drug. I think it did show a very good response. It did show almost 70% response. Here, capecitabine is given as 750 milligram in 2 divided days doses from day 1 to day 4. Temozolomide is given day 10 to day 14 in 28 days cycle. There were some adverse events, but this, especially we are using temozolomide capecitabine combination in grade 2 and grade 3, which has shown good response. So the nuclear medicine based therapy, there are 2 drugs. One is the yttrium, other one is the lutetium. They differ, with each other in a part of emitted particles. Overall response rate is almost up to 30%. There are some positive trials in this group. One of the concerns with this trial is that there is the long-term toxicity is one of the things which is always discussed in this group of treatments. So Nectar study is in one of the study we did prove that this combination of actrotide with that of the nuclear medicine therapy could be very beneficial. This is the study which was done on progression with patients who have received actrotide already. Whoever have progressed on actrotide, in them one arm continued to receive actrotide. In other arm, nuclear medicine based therapy was given to in combination with that of the actrotide. It had a 5 years of follow-up. If you see the lutetium in combination with actrotide, did show a very good, significant progression-free survival benefit compared to that of the continuing actrotide alone. It did also show overall survival benefit. So if a patient has progressed on the actrotide or anything, then the combination with actrotide with the nuclear medicine therapy would be useful. So dosing, I think there are, as I was telling you, there was lutetium and yttrium. So yttrium number of cycles are 2 to 4. The time interval between 2 cycles is 6 to 12 weeks. Whereas in the lutetium, it is 3 to 5 and time interval is 6 to 12 weeks. It's always these therapies are given with the amino acid because these therapies can have a side effect on kidney. So most often they are given with along with the amino acids to counter the kidney side effects of the treatment. So wait and watch policy we can do in a low burden tumor and a patient we have a tumor which has low proliferative index, especially grade 1 and low grade 2. In a patient who is having stable disease. So patient who is having low tumor burden, stable disease and low grade, wait and watch policy can be tried. You can also use actrotide if you want. So treatment algorithm, basically as I was telling you, if surgery is feasible, kindly do the surgery and remove it. That's the only way of cure. Then after that, if surgery is not feasible, you have to look into the what grade and K67 group it is falling into grade 1, grade 2 or grade 3. In grade 1, you can use somatostatin analogs. There is also some trial with everolimus. In grade 2, you can give everolimus and nuclear medicine based therapy. Temozolomide capecitabine is something which is coming up very fast. In a patient with carcinoma, you always go for the chemotherapy. If K67 is low with grade 3, then temozolomide and capecitabine or avastin can be used as a treatment option to counter the disease progression. With this, I thank you.
Okay. Thank you so much, Dr. Suresh sir. It was indeed a very insightful presentation where we got to know a great information about the JEPNET and the recent practices or the recent management that is being practiced in JEPNET. So, with this, I would like to move ahead with the next session. So, now we'll be going ahead with two case presentations. The case one presentation, let us start with the case one presentation. So, for the moderator for case one presentation is Dr. Rajiv Vijay Kumar sir. He is a consultant medical oncologist, BGS, Glyn Angles Hospital, Bangalore. And the panelist for this case presentation would be Dr. Sneha Kominani, consultant medical oncologist, Astor Whitefield Hospital, Bangalore. Dr. Manish Kumar sir, consultant medical oncologist, Solaris Cancer Center, Bangalore. Dr. Smita C. Ma'am, consultant medical oncologist, Kidwai Memorial Institute of Oncology, Bangalore. Dr. Sampath Kumar MN sir, consultant medical oncologist, Magnum Onco Care and Manipal Hospital, Bangalore. Dr. Vijay Kumar sir, consultant medical oncologist, Sparsh Hospital, Bangalore. With this, I would like to hand over the session to Dr. Rajiv sir. Over to you, Dr. Rajiv sir.
Hi,
Hello, sir.
good evening. Is the screen visible now?
Yes, just put it full
Yes,
screen,
sir,
sir.
it's visible, sir.
First of all, a big hello to all my colleagues. I can see after going through the initial slide, I got a view of my inner MBBS as well with Dr. Poonam Maurya as well. So she will, after this, if anyone is very stressed out, I'm sure that Dr. Poonam would actually ease out all our stresses in life.
Sir, if you can just put slides on a
How
full
to
screen
think
mode.
happy. She's probably, you can have a session with her. That I think every talk from now on should have Dr. Poonam easing out all our stresses in life with that. I have my very senior colleague from Army Hospital, Dr. Manish Kumar as well. My dear colleague, contemporary, Dr. Smita, my dear friend Vijay, upcoming star of oncology, Dr. Sneha as well. So, well,
Dr.
Dr.
Rajiv,
Rajiv,
if you
sir?
can just put it full screen, sir.
Yes,
it
sir.
is full screen.
No, sir, it's
It
not.
is not visible on the screen, sir.
Oh, now full screen. Now is it full screen?
No, sir. If you can just reshare it again, sir.
Stop share. Share. Now?
It is not coming in a full screen, sir.
It is not full screen, sir.
Still okay. Yeah, let's go ahead. It's fine.
Just go ahead. I'm
No
sure
problem.
everyone can see. Allah.
Yeah, it can be very well seen, and Rajiv will take care by asking questions. It's fine.
All
See
right.
and hear him. That's enough. Yeah, you can go ahead.
Now the problem is that it's not seen in my screen. Okay. So we're having
Hey, now it's full screen.
Oh, fantastic. So we have a patient who's come from the last 15, 20 years. This is like how probably evolution of medicine and evolution of therapies for neuroendocrine tumors as well. We had a 70-year-old gentleman, patient with hypertension post Cabot status. They had ischemic heart disease, presented with generalized weakness since a year, fever, low-grade intermittent type, cough, no wheezing, flushing, or diarrhea, no other significant history. Clinically, there's nothing. Lab parameters showed that his CBCs were normal, creats were normal, and they mentioned the chromogranin A level. Probably he had got ultrasound done, then probably CT scan, PET scan, and so on and so forth. He had a mass in the pancreas along with multiple liver SOLs, and to take away the surprise, the chromogranin was 5540. Again, CT scan also showed the same thing. And FNAC showed presence of a neuroendocrine tumor. This was the time in that time that we were worried of poking the liver or poking the pancreas, I suppose, in 2005. Nevertheless, it came out as a neuroendocrine tumor with a low Ki67 of less than 2%. So coming out as a grade 1 neuroendocrine tumor. So these were the pictures. And then subsequently, Sarkar 2011, those things are gone. Okay. So in 2011, He had a DOTA scan done that showcased almost the whole of the liver being involved by the tumor, along with the pancreatic mass. It showed, it's there for all of us to see. So basically, we had a diagnosis of a neuroendocrine tumor of the pancreas with liver metastases. So, and then he was started on therapy with Afinitor, which was the research molecule that time for everolimus, 10 mg daily. So, if I can ask my colleagues, if I ask my dear friend Vijay, are you there?
Hi, Rajiv. Yes,
Hi,
yes.
hi. So, Vijay, how many of our patients, your patients with, what would you do in this kind of a scenario? Patient with a grade 1 NET of the pancreas with the whole liver studied with tumor. We started in this patient, we see that they started off with sandostatin LAR and everolimus. Would you do something similar to this? They're given 20 milligrams of sandostatin. Anything that you would like to do? Or you do different?
So, firstly, I think patient is clearly symptomatic with the disease,
Correct.
high burden, and the somatostatin receptor uptake is also clearly seen. So, the standard of care would be to start with somatostatin receptor antagonists clearly. We would go with either octreotide or lanreotide based on finances of the patient. Along with that, because of the tumor burden being very high, in selected patients, you would have a discussion combining with temozolomide, which is what is the standard of care. But most of the time, the single agent alone and wait and watch until and unless we feel that there is no response, and then kind of add the second drug, which is our capecitabine temozolomide, only with a high tumor burden, which is what we see in this patient. So everolimus in the first line, I would probably hold it back purely because of the experience with the drug. It's a notorious drug. We know it, the toxicities are bad. So primarily that is what would be my take. Provided the echo is normal and all the other parameters are sorted, patient doesn't have any Cushingoid features. Once you're happy starting the patient on somatostatin SSTRs primarily, SSAs.
All right. If may I ask my Dr. Manish, so you've been there in the army for a long time. You've been seeing this when resource limited settings as well. What's your take on this? What would you do in 2011 when you were at RR?
Yeah, I think that time I was named. So this exactly we used to do. So that time starting, especially in pancreatic NET, adding everolimus used to be in additional reason that okay, in other NETs probably sandostatin alone was good enough, but in pancreatic NET we did use this combination in particular. So probably it would have been my choice as well at that point of time. Yeah.
Now, what would you do different if this patient came to 2025?
Well, now, as I say, that we have multiple options. We could have used lanreotide, we could have used Captem, as Vijay was saying. I completely agree. Though, of course, as you said, that Ki-67 is just around less
Yeah,
than
would
2.
you use Captem in grade 1? Or
Sorry?
is it like...
That's what I'm saying. I'm just coming to that. Yeah, that's what I'm saying. As you said, that Ki-67 is less than 2, and probably that would have been a factor that I may not have used it. But if somebody with this kind of picture in a higher Ki-67, Captam would have also been an option. Otherwise, either lanreotide, sandostatin LAR, either of them I could have used. And maybe even now, if nothing stops me from using this combination. But yeah, I may prefer to use a lower dose. Like everolimus, even I have seen that 10 milligram difficult dose to tolerate. So maybe a lower dose I would have preferred 5 milligram.
Perfect. Has anyone used lanreotide? Because I've never used the drug. Is it available? Someone please educate me on that. Because we all use octreotide, so I've never used lanreotide. So well, that's I take that as a no. But Dr. Smita, have you ever used? Now see here he's used 20 milligrams. Most of us you end up using 30 milligrams as a standard dose these days. Have you ever used or thought of giving 60 milligram dose of sandostatin LAR?
So I think I have never used 60 mg. So most of the patients I tend to use 30 mg octreotide LAR. 60 mg, I think I have no experience with 60 mg. And I think this particular patient, if it was like now presently, probably I'm comfortable using only the sandostatin LAR. But because pancreatic everolimus has good data, probably we should have started with the 5 mg dose, because we
Very
know our
nice.
patients never tolerate the 10 mg everolimus.
Correct. Completely agree with you on that. It's like 5 mg is the go-to with most of our colleagues whenever we've spoken across the board. Everyone starts with 5 because with 5 itself, many people start having a lot of oral
Because of this,
ulcers,
yes.
diarrhea, fatigue, and they're like sustu, and they're not able to explain the kind of agonies that they go through with 10 mg. So 5 mg is like the very, very apt therapy which we use. 10 mg probably is more for the Western population. Dr. Sampath, do you have any viewpoints on that? On dose of everolimus?
Not in this. I'll go with it's a low high burden disease. Why can't we start with the PRRT, peptide receptor
Thank you.
radionucleotide
That's
therapy with
very
somatostatin?
nice. Very nice. That's actually earlier PRRT was relegated to the 3rd or 4th line after you've
Yeah.
exhausted. Then now in the last couple of years, PRRT has climbed up the ladder, and if you have a PRRT, I think SSTR positive tumor, why not? You should be able to exhibit the drug and give it. Now there is enough.
Yeah, it is a very yes, it's a very high burden disease.
I agree with you, Dr. Sampath. That's like
somatostatin and everolimus may not help here. So mostly we have to start with the PRRT because we need, and it becomes very torture because it
And
comes
when you're
again with
giving PRRT, what else would you? How frequently would you do you give in sense, or what do you like to give PRRT? And
so
what
it's a
what drug?
completely a nuclear medicine call. Most of the time they give one sitting. After 2 months again, at least maximum 3 doses they can give. That's all.
Very well. So like Dr. Sampath said, we give around it's cycled once every 3 months, and you can give up to a maximum of around 4 sittings because it has its own set of side effects. It causes severe bone marrow suppression, to say the least. And I'm sure it's like if I can go to Dr. Sneha. Dr. Sneha, how would you agree in giving PRRT to this patient?
Sir, I missed the first sentence
Oh,
itself.
it's nothing. Would you agree in giving PRRT to this patient upfront? Now he's a very symptomatic patient with extensive liver metastases, and you've done a DOTA PET scan, and it's lighting up like a Christmas tree. Would you like to give him PRRT, or would you like to do the standard rigmarole of going ahead with sandostatin LAR? What would you like to do?
Grade 2 with the K67 in
Grade
what
1,
range?
grade 1. It's a less than 2%.
Less than 2%, grade 1 PRRT is not that good, sir. So I would definitely, if that much symptomatic grade 1 with extensive disease, probably with the highest uptake area, probably I will try to take a rebiopsy and then decide about the PRRT.
Okay.
I have a little different, slightly different view, Rajiv. Like, as far as I remember, if I don't know the extent of liver involvement, but if liver involvement percentage around touching 50% or beyond, then generally PRRT is not very effective if very high liver burden is there. Once again, lesser liver burden, yes, it's a good option. And a second point is that in very, say, high-grade disease, again, PRRT is not a great choice. And third point, as we said, that most of the PRRT is obviously given by our nuclear medicine colleagues. I mean, this is what I have seen, that if I send a patient to a nuclear medicine fellow for PRRT, if I send him in the first line, the very next moment I'll get a call that why did you send the patient to me? Or why didn't you try another option before giving PRRT? Maybe nowadays people are giving. I'm not aware, but this is a practical problem that I face.
Correct. So it's now climbed up the ladder, like I mentioned, in the last couple of years. Like you're very right to say that even the nuclear medicine doctors were not very keen on using it as a first line, even just 2.5 years back. So they used to, when they just started flirting with the idea, saying that why we can actually think of giving it in the first line. And then in the recent past, there are patients who have started, and even in the neuroendocrine clinics in MD Anderson also, they are offering PRRT as first line. In a couple of my patients who are there, I learned from those patients that they are using it first line. So, Dr. Vijay, now once a patient comes like this to you, you have a biopsy, say, showcasing less than 2%, but the patient is extremely symptomatic, like you said. Are you happy with the DOTA PET, or would you like to have any other type of imaging? It's very symptomatic. You have a less than 2% Chi67. Are you happy with the result? Sneha mentioned that she would like to have another biopsy elsewhere. Do you agree with that, or would you like to have another set of imagings? Vijay?
So as long as there is a DOTA PET done, I am okay with it. And in terms of rebiopsy, to be very frank, as long as the biopsy is taken from a site which is where there is adequate tissue and the pathologist is like, you kind of take into multiple factors. If you have a good pathologist and you clearly trust in her in all of it, because it's purely a pathological diagnosis, and if it's fitting in, then it is what it is. If the key is low, it is low. So I don't really see a difference in doing a repeat biopsy and trying to show whether it's a higher grade.
Okay, so now you're done with the, no, we're not repeating a biopsy. Would you like to do another set of imaging? I'm asking you, comes with a catch, of course.
So,
what other imaging would you like to do?
We've done a DOTA PET, correct?
Correct.
DOTA PET.
FDG PET,
Correct. So, so Sampath, spill the beans. So would you like to do a combine? Because right now, most nuclear medicine doctors, including at HCG and every other center of repute, are doing now dual PETs. They're doing both FDG as well as DOTA PETs. Dr. Sampath, your viewpoints on that dual PET now that you brought spill the beans. Would you like to
see, Vijay, if it is if you do a Dotanac PET, you are very confident that's a very high uptake. I don't need to go for the second biopsy or the second FDG PET CT scan. If you have a dilemma, then I think you can use those tools.
Dilemma in what? Since you have a biopsy, the biopsy shows grade 2 NET. There is no grade 1 NET, so there is no confusion. Well, let's consider if it's grade 2 NET. Then what would you do? If it's grade 2, then would you ask for a FDG PET?
Yes,
No.
like that. That time, that again, that is okay.
So if I may, so what we would normally do is we would start off with a FDG PET to start with, because that will be our initial imaging modality. We would do an FDG PET if the chromogranin levels are not there, which is again, see, if you go by your routines, when you work up there is a liver SOL, how many times will we order for serum chromogranin? Let's be very practical. Although we do, most of the times we will still probably get a FDG PET and then subsequently order a chromogranin, because that is what happens. Very rarely that because there is a liver SOL, you would order, do a serum chromogranin and then order.
No, since that, if I may just, Vijay, you would probably do a biopsy, right? If you see an SOL before going in for a PET, then comes as NET grade 2. And then afterwards, then what would you do?
So I would differ in that. Before doing a biopsy, I would do an imaging to know the site of maximum FDG activity, so that I am not wasting a preferred site for biopsy. So I would definitely have a baseline imaging. Based on that, I would proceed. And once the chromogranin is high, then that is where I would probably bring in the angle of doing another another DOTA TATE.
Okay, let's take the opinion of Dr. Smita. What would you like to do, Dr. Smita?
So I think normally we do, when the low Ki67, since this patient was only 2%, we are comfortable doing a DOTA.
If it's, I change the setting. It's a grade 2. That's a
if it's a grade 2, then the role of PET and DOTA NAC both comes in picture. So
why would you do that? Very nice. Thank you. Thank you for that answer. But why would you do that?
So because I think the thing is, in grade 2, earlier days it was like we should treat the grade 2 like grade 1 itself. But now the grade 2, if the uptake is more on the PET, you treat it like a carcinoma. So that is why the difference.
Very nice. So this is the concept. It keeps changing, that if it is a grade 1, you know that it's going to respond beautifully to PRRT. So I'm sure all of us know that if you have a disease, you will have a certain part of the tumor which is more DOTA avid, certain part of the tumor which is more FDG avid. So when you look at the images, see the CT component of it, the size might be, let's consider 7:8, but you look at the DOTA component, it might be 6:5. And then when you look at the FDG component, you might get it in 3:4. So therefore, there will be an overlap, like a Venn diagram. You'll have certain parts which are purely DOTA avid, certain parts which are purely FDG avid, certain parts which are a mixture of both. So that's how, because we all know that it's a very heterogeneous tumor. It's not going to be grade 1 all throughout the tumor as well. So certain areas are going to be different. So you can expect that you can also probably prognosticate, saying that this patient is going to respond well to my sandostatin / everolimus / sunitinib for some period of time, and then there's going to be a bit of a progression. If it's mainly hardly FDG avid and mainly DOTA avid, you know that this patient is in for the long haul. So that's one of the stuff. So this gentleman had some problems with
Rajiv.
Sir.
You have almost finished my panel anyway, but this question, yours, how, I mean, Vijay had a very practical point, no? So if the patient has done a PET CT, patient, most of the time, it is not that every time there will be a biopsy Ki67 report before a scan is done. And FDG is showing uptake. Report comes as neuroendocrine.
Correct.
How many of us, I mean, mostly the patient gets a DOTA PET, but how many times it changes our management?
Well, this is exactly a very important, pertinent point. I'm bringing to the question, bringing to the table, should we do dual PET? I've started doing dual PET. I've started seeing huge differences in between the DOTA avidity part and the FDG avidity part. The last 1.5 years, I've been doing dual PET, and I have been very surprised where FDG PET has picked up more. DOTA is negative in those areas. Those areas have already transformed into a small cell carcinoma when I biopsied those. Therefore, I'm again bringing to this, setting the cat amongst the pigeons. What's your practice, Prasad sir?
No, I mean, it's a mixed bag. I'm not saying that I practice one of them, but I have not routinely started doing this dual PET thing.
Okay.
I don't know what other panelists feel, but because it is an interesting point that you are saying.
Correct.
And Sneha's point, no, that this repeat biopsy. I mean,
Correct.
how many of us actually do multiple biopsies in neuroendocrine to see whether there is a difference in the different areas?
Most of us will start off with these simple therapies. The patient will progress after some time. Then you'll repeat. Then you'll find a higher grade tumor elsewhere. Then you'll swap therapies thereafter. That is generally been the normal practice amongst most of us.
Prasad sir, if I may, for your first question. So before starting octreotide alone, we would want to know whether the somatostatin receptor uptake is there or no. So only in such situation, I would, because we have a grade 1 report on the histopath, I would still go back and do a DOTA TATE just to confirm that there is receptor positivity, because then our drug will work.
Correct.
There could be grade 1s which are receptor negative. That is not rare. There are grade 1s or grade 2s for that matter, which can have receptor negativity. So just to confirm the somatostatin receptor uptake positivity, I would still do a DOTA TATE. That is the place where I would do both.
I think DOTA TATE is goes without saying, no, Vijay. Like you said, no, none of us will do a chromogranin, like you rightly said. If you're doing a FDG18, then DOTA TATE becomes mandatory before you start off your sandostatin / everolimus, any of the.
Rajiv, if I may add this point, this discussion mainly of academic importance, but in practical life, what Dr. Vijay brought out is very correct, that when I see a patient with pancreatic mass and liver lesion, the first thing I'll order obviously is tumor markers, and along with that I'll order a PET, because it rarely happens that you do a biopsy, then you wait for 3-4 days for the biopsy report to come, and then you order PET or say DOTA PET. So normally patient end up getting PET and tumor marker, and by chance if it shows neuroendocrine, then if we have to see the SSTR avidity, and then we ask for chromogranin and
DOTA PET after that.
DOTA PET. So that's what actually happens on ground, right? So most of us do that, and it's very rare to see. In fact, it's a surprise to me that why would somebody do PET and DOTA PET in one go? Because in low-grade tumors, PET has no value. Like in this case, say grade 1, PET will not show you anything. Whereas in high grade,
I think we're
DOTA PET
going
will not be
in
effective.
circles, sir, because what Vijay mentioned, you're doing a FDG18 PET biopsy. Then afterwards, then if it comes as neuroendocrine, then we're doing a DOTA PET.
This exactly happens. This, most of us exactly do the same, because this is the situation. Yeah.
So fine. I was giving another scenario. Once suppose you done a biopsy, you get it as a neuroendocrine tumor. Are you going to do only FDG18 or only DOTA, or are you going to do DOTA plus FDG18? That is the question that I had put forth.
No, I'll obviously do DOTA PET. If I get a neuroendocrine tumor, I'll go do DOTA PET. Obviously, I want to know the avidity. That's what.
Rajesh, just one point. I think the doing imaging first before biopsy is something, I think, unwanted discussion, I believe. Because now I don't know how much Dr. Manish and Vijay are seeing patient walking to them without any scan. Most of the time people walk to us with scan, not with PET scan. They will walk us with CT scan. So this discussion of doing imaging before this thing. As a academic, after diagnosis only you do PET, right?
Correct.
How many of the pancreatic cancer have just walked into your OPD without any scanning time?
Agreed.
Most of the time you will have CT scan, you will not have PET scan. So
agreed.
So when your CT scan is there, then you do this thing. PET scan will come later on. That's very few people, I believe.
After biopsy, we generally end up doing the PET scan.
Yeah, absolutely.
Okay, we'll leave that for another day. I agree, sir. I thank you for all of you all for the different thought processes. Agreed, all of them. So this gentleman received some everolimus for some time. He got all sick with it, and then afterwards he stopped it. He was continued on sandostatin LAR, then he improved, and then he had again disease progression he had. Then again he went on. Now, what are the therapies which are there that were there? Restarting everolimus with a smaller dose, or sunitinib, or TACE, or PRRT. Then he just continued on sandostatin LAR. Then in the chromogranin came down to 562. And he started developing receiving PRRT. And then he received around 3 doses of PRRT. And then we see that the disease had responded well. So these are not the questions which I have actually put forth, but actually most of the questions that I wanted to discuss on this, I have discussed to a certain extent. So what other stuff would you all do? In sense that now it's been like 4-5 years. I'll put the question now. It's been 5-6 years of completing therapy. He's been having a decent quality life. And then after he comes back with disease progression, his chromogranin level stays, let's consider it had come down to 300. It's now around 350 or 400. And he's got more new lesions in his liver. What would we do? Can I ask Sampath?
Okay. Now he is having a lesions in the liver, right?
Yeah, liver lesions have increased, but the increase in the chromogranin A level has been from 300 to 350. That's all. It's not jumped up too much.
Okay. Just think so disease-free survival almost 4 years, is right?
Correct.
I think we should do biopsy and imaging both.
Very true. Now, what imaging would you do, Dr. Sampath?
Now, as you said, I agree with you. It is yes, I will combine both FDG and DOTANAC. Is it turned out to be a grade 3 or grade 2? I wanted to check.
So, like Vijay mentioned, he will do the and like you also agree, you do the imaging, and then so therefore you will do a biopsy from that most probable area. And if it comes out, let's consider it comes out. How frequently, if I may ask, thank you for that, Sneha. When you repeat rebiopsy, I'm sure you've rebiopsied pancreatic NETs or any other NETs in your career. Does a grade change from grade 1 to grade 2 or grade 3? How commonly have you seen this?
Sir, it does when the behavior is not like to the textbook. Grade 1 usually is symptomatic and not major symptoms and all that. But if that is not correlating or fast progression, definitely we are seeing grade change, sir.
Correct. So therefore, there's a great change in what therapy would you offer then? Something which like already Suresh Babu sir told.
Yes, sir. So if the grade is changed to a like grade 2 K67 in the moderate range and DOTANAC positive, then PRRT. Suppose if it is going to grade 3 and very high K67, then chemotherapy options. Or when FDG and good DOTA mismatch is there, where FDG uptake is there, then probably I would consider adding temozolomide and capecitabine like that, depending upon.
Correct. So CAPTEM regimen. So you're comfortable with, many of us have been using large amount of CAPTEM regimen for our tumors. And then once the disease progresses on that, you again send the patient back for PRRT at some point in time. If I may ask someone who's practicing some high tech now, anyways, Sneha, I've asked Vijay, what kind of PRRT when you send? Do you ask for like, are there any other different varieties that you know of? PRRTs or any of my panelists? I just want to finish off. How many minutes more do I have? Or have I finished already crossed my time?
I think we've crossed our time, but I'll take this quickly. So
yeah, this will be the last question. Yes, please.
177 based. So we use that. It's usually given once every 8 to 12 weeks, and we give up to 4 to 6 cycles. And the data is primarily from Netter2. So in the first line for grade 2 and grade 3, with key up to 55% is where this is. So this also had pancreatic NETs in the study. So we give up to usually 3 to 4 cycles is sufficient. Most of the times you get excellent responses in 2 doses of PRRT because the toxicity is pretty stiff. Marrow separation, like you mentioned, a lot of organ dysfunction sets in beyond 3 and 4 doses. But we usually span it out by a good 8 weeks. 8 to 12 is the standard. and lutetium based is what we use. But there are a lot of clinical trials which are happening in that space because there are a lot of beta emitters, especially for bone alone, strontium based, actinium based. There are a lot of these which are very actively recruiting patients now because the trend of treating even grade 3 neuroendocrines, the key up to 55%, is also moving towards more of PRRTs right now. So we're getting PRRTs across tumors, even in lung NETs. There is a lot of studies which are starting to use PRRTs in excellent responses. And you have a lot of these long-term responders doing very well for 8, 10, 12 years on PRRT. So that's where the spectrum is right now. So we're moving towards the PRRT era is what I would say.
Perfect. Thank you. Thank you. And just an ode to one of our Steve Jobs. If he had probably had the surgery upfront, local therapy, then probably he would have yet been alive. So he chose to take alternative therapy, and then he became metastatic, and then he came on to conventional therapy, and then we all know what happened to him. He just didn't survive beyond 6 years of neuroendocrine tumor pancreas. So with that, I thank all my esteemed panelists, and I hand over the stage to Dr. Prasad Narayan to finish the rest of it. Thank you.
Thank you so much, sir. Thank you, Dr. Rajiv, sir. It was indeed a very elaborative discussion, and all the panelists as well. So now I would welcome our moderator for the second case presentation. So second case presentation again is on gastroenteropancreatic neuroendocrine tumors, and the moderator for the session is Dr. Prasad Narayana, sir. He is a consultant medical oncologist, Site Care Cancer Hospital, Bangalore. And the panelists for this case presentation are Dr. Poonam Maurya ma'am. She is a consultant medical oncologist, Apollo Hospital, Bangalore. Dr. L.K. Rajiv sir, consultant medical oncologist, Kidwai Memorial Institute of Oncology, Bangalore. Dr. Amit Kumar Jain sir, again he is a consultant medical oncologist, Bhagwan Mahavir Jain Hospital, Bangalore. Dr. Nandish Kumar sir, consultant medical oncologist, HCG Cancer Center, Gulbarg. Dr. Mangesh Kamath sir, he is a consultant medical oncologist, Fortis Hospital, Bangalore. With this, I would like to hand over the session to Dr. Prasad sir. Over to you, sir.
Hi, thank you. Good evening. So I think there will be a lot of repeat in what we are going to discuss. So I would try to make it in a different way. We have are the slides visible?
Yes,
Yes,
sir.
sir. Yes,
Yes,
please
sir.
go ahead, sir.
And all the panelists are there.
Yes, sir.
Yes,
Yes,
sir.
sir, we are there.
Nandish, you are there, is it?
Yes, sir. He's there.
So I think it's a after a long time I am seeing Nandish in a panel actually. That's why I asked. Nandish,
Yes, sir.
how are you?
I'm fine, sir. Thank
How is
you.
Gulbarga?
Pardon, sir?
How is Gulbarga?
Fine, sir. Raining a lot. मलनाडु बन गया हमारा गांव.
Wow. So let us start this case. It is something similar to what what Rajiv was discussing. So this is a usual presentation. We have a young patient coming with gastric outlet obstruction, pancreatic mass with liver mets. So patient goes to the gastro, and because of the obstruction, he gets a duodenal stenting done. And by a US guided FNAC, FNAB shows epithelial malignancy. It is positive for CK, synaptophysin, and negative for CK7 and 20, and KI is 1%. So well differentiated neuroendocrine tumor, grade 1. So we'll start with Rajiv. Rajiv sir. Dr. Rajiv is there, Dr. LK Rajiv?
Yes, I am there.
So what will you do if you are seeing this patient in Kidwai? You have this report with you. Next, what will you do? Because we heard about getting FDG PET, Dotonok PET. You have suppose you want to treat it with in a resource constrained setting. That is why I am specifically asking you this question.
As you said, we are resource constrained, but we have PET scan and Dotanac also.
No, but
So,
what is your, if you are going to approve one test and you want to maximize,
if I have this report in my hand, I will ask for Dotanac scan.
Dotanox scan. Okay. Mangesh, what will you do? First question, will you wait for the biopsy report to come before asking for scan, or you would have done a scan for this patient already?
So definitely, I would wait for the biopsy report because then it will also help me to decide on the scan. My personal recommendation to patients always is to do dual scan initially, and if they can't, then probably just do a Dotanoc. These are some of the things. So I would definitely like to see the biopsy report.
So this dual scan thing, since it was discussed by Rajiv as well, how is the cost? Is there a cost difference for this? Can you just throw some light on that?
I am not handling much of it at Fortis. Like we just go directly. I have not bothered to see, but definitely I think there is an addition of the FDG cost at a lower limit. But I am not very sure about this.
Anybody knows in the panel? Poonam, you know about this?
So roughly it costs 40,000. That's what I heard. And I
Okay.
think it is done on 2 days, not one single day.
Oh, okay. Okay.
Exactly.
Yeah, it
Recently, one of
cannot
my
be done in single day. Yeah.
Poonam, you said your voice was breaking. So you said it is done in a single day, is it?
Yeah, I was just saying same thing. Both this cannot be done in a club in a single day simply because both the dyes are different.
Right,
And the cost, basically, we have to negotiate with the nuclear medicine. So they do reduce the cost. Otherwise, as he said, it is like 40, but we'll have to negotiate. That's it. Because these kind of patients are also very rare, no? It's
Right.
not a common thing. Yeah.
Amit,
This-
what is your opinion here? You will do what can?
Prasad,
Yeah.
regarding the cost, recently, one of my patients got it in TMH for free, dual
Okay.
scan. I don't know what scheme he got it.
Okay. Okay. Fine. Yeah. TMH is different. Yeah. Amit,
Yes.
your
So
practice.
most of the
What?
time from my hospital, I send it to HCG. At 25, they do both, sir, FTG and the Dotanac, sir.
Right. So I will not go into the classification because Suresh has already
That's
told about this.
Prasad sir,
Yes,
may I
Venkatesh,
say?
yes. Yes.
Sir, now you are talking about Kidwai resource stand. I'll go to next level to our place.
Yeah.
It cannot afford Dotanac scan also.
Right.
So if the pathology report is showing grade 1 tumor and if you say clinical is fine, so am I correct going directly with Sandostatin LR without doing Dotanac?
I would, this is a very,
Yes.
I think it is fine. I mean, what were we doing before we had all these scans at hand
Yes,
here?
that time we were giving you.
Right, right. And also, I have treated patients, I mean, since I can say that with authority that it was not as if all the patients wanted, it was mandatory to get a Dotanoc PET CT. But nowadays, it is sometimes we see FAPI PET CT and Dotanoc PET CT done on different days for same patient actually. So even FAPI scans are very popular these days for some reason.
Prasad,
Yeah.
there are two things in that.
Yeah.
One is that if you don't do Dotanac PET in upfront, how will you assess the response? That is number one.
Right.
Number two is that, we know the tumor heterogeneity. Dotanac PET is done basically to reassure you that your serotonin after rate is going to work. For some reason, you do Dotanac PET scan and it is not showing uptake any, then giving the after rate is not going to be of any use, isn't it? Theoretically.
We agree,
Yeah,
sir.
that is theoretical. And I mean, we would want to get a Dotanoc PET CT if it's feasible. We were
If
just
finances are constraints, then we cannot. I mean, they cannot. Then yeah, we have
so
to save
Suresh,
money for the treatment.
if I say that if this patient has already, I mean, we discussed in the previous case also, suppose you have a FDG PET done already.
Okay.
You have got this report as grade 1 and
Okay.
FDG is not showing much uptake. Why
Yeah.
should we actually get a Dotanoc PETs? Why is it mandatory?
Correct.
What
Correct.
I'm
Agreed. Yeah.
telling, baseline, you
Sir,
have to do some imaging, right?
Right.
Prasad, shall I have a comment?
Let Suresh finish and then we can have the comment. Yeah.
So if somebody has done FDG PET, I have no issues. I am against the thing that without any imaging doing is I don't agree.
Right. Yeah. The comment from because I cannot.
Rajiv,
Rajiv. Yeah. Rajiv. Yeah.
See, with due respect, because when the patient is not affordable for Dotana, and
Yeah.
we start an Sandostatin, even the cheapest brand will cost 10,000,
Right.
and it has to be given continuously. Even placebo control trial also, it has not shown much benefit.
Right.
In that is the case, why you want to give? You can observe also, no?
Yes, that is fair option, sir.
Fair.
That is,
No,
so
but
I feel if at all if you want to considering LAR, you have to do the Dotanac. That will be the better approach because you are unnecessarily burdening with a medicine when the molecule which may not work also.
Absolutely, Rajiv, fully agreed. But question was repeating a scan after getting an FTG. That was the point here. Anyway, so this patient got a Dotanoc PET scan and it confirmed what we already know. So this is the PET scan actually, and different options of therapy discussed here. What we will ask Dr. Poonam. Dr. Poonam, what will you suggest as option of therapy? Rajiv discussed about that PRRT therapies are coming in first line, and I know that PRRT therapy is becoming more popular, and it also depends upon which institution you are in. So, what is your first line therapy for this patient, and why?
Because the Dotonat PET is showing so much of avidity, I would directly go for octreotide LAR therapy.
Mhm. What about PRRT therapy as first line?
No, not as first line. I mean, I have not sent anyone first line for PRRT therapy. And PRRT therapy also has its own toxicity, bone marrow suppression, tolerability issues. So when we know that LAR therapy is quite tolerable, results are also good. So I think I would go with octreotide LAR therapy only.
Mangesh, any reason for you to choose PRRT therapy for this patient?
Not at all.
Not at all.
Not at all. Not in this profile with this kind of symptomatology. Not something I feel emergently requires PRRT.
Amit, any reason why you would consider PRRT therapy for a patient with grade 1 in the first line itself? Whether can you say why you want to consider in some patient? I'm not saying you want to do it for this patient, but which patients do you go for a upfront PRRT therapy in a grade 1 in ET?
Grade 1 upfront, not much. Only if there is an extensive disease. When I was working in Shankara, along with PRRT therapy, they used to give Captam to the patients.
Mm.
So, and it showed some good response in the patients who were being treated in. So, what is it? Discuss with the patients. Cost is one important factor which plays in, sir. Because most of the time PRRT therapy it goes in lakhs, and
Right.
it's not just one session. And
Right.
this patient had intestinal obstruction, I guess, sir.
Yes, and it
So
was put, yeah.
shouldn't surgery be done first to
That
relieve the
was stented,
obstruction?
and then after that, a repeat barium was done, which showed no obstruction. I did not mention that because
So, but in neuroendocrine, how good is the stenting option? Because we have seen in few patients it has not worked well. Stent migration, I've seen a lot happening,
specific to
especially in
neuroendocrine,
neuroendocrine.
is it?
Yeah, in neuroendocrine, sir.
And why should that happen in neuroendocrine specifically?
No idea, but a few cases I've seen. Recently had a duodenal NET. Stenting didn't work, so I had to do gastrojejunostomy to the patient. And
Sure. Dr. Rajiv, your answer to this question of stenting versus surgery?
Don't have any experience. Most of the time we go for surgery only.
Right.
Stunting is not.
So I will not go into this trial. So this patient was started on octreotide and had a great response, continued response in December, continued response in September 2020, for almost 1.5 years on this actually. So how long do you treat such patients? The patient is asymptomatic. Patient is taking the treatment and doing well. So is there a limit to which you treat, or you treat till progression, or dose limiting toxicities? Let us ask Nandish, how long do you treat?
Sir, usually till the progression.
Right. So you treat for life actually, right?
Yeah, till progression. Yes.
Is there any, Mangesh, is there any concern of long-term use of octreotide? Do you face this SSA resistant carcinoid syndrome? How long, when do you usually see this resistance coming?
So one definitely a problem with continuation for a long time is that there will be tachyphylaxis. We understand that. And so we will have all those things that render us resistant to some of the targeted therapy that we already use. So one major problem with the whole continuation is that you will lose response. You may add on something, or you may have to change the schedule or put something a lot more efficacious than that. This is one major strategy. There are some strategies where they do stop it for like 2 3 months and then restart it. I have seen a few prescriptions like that. I don't think there is any basis for it. I mean, I think it's mostly stopped because of either financial or toxicity. You are just trying, or you're trying to think that you can reactivate the receptors, but actually it can work against us. So that is definitely one major challenge that we have of continuation.
Right. So we will quickly take one more case. This is a 58-year-old lady, indigestion, weight loss, bilobar liver mets, then stomach mass, perigastric nodes, lot of disease actually. The only thing which can work in favor is if it's a neuroendocrine tumor. If it's an adenocarcinoma, this is really bad disease in the scan. So there is a liver surface deposit and a gastric biopsy. The gastric biopsy is showing well differentiated neuroendocrine tumor grade 2 Ki of 15%. So again, a Dotonok PET scan confirming what we know from the previous thing. The stomach lesion, lymph node, peritoneal, omental deposits show more FDG uptake here. Perihepatic deposits show evidence of internal necrosis. So my question to Dr. Poonam, do you do a multiple biopsies if there is a differential seen? This is the grade 2 on biopsy. Do you do a if there is FDG and Dotonok, I mean discrepancy?
Match.
Do biopsy to confirm?
Okay. But this patient underwent only
No,
Dotonac,
no.
no? Previous slide.
No, I'm just asking this patient, and as per this patient underwent PET also, because there was a comparison with the PET before. But the question is whether do you do biopsies to differentiate this, like Rajiv was saying?
We don't do multiple biopsies very often, only when there is doubt. Suppose markers are not elevated and the normal FDG PET is showing a lot of uptake. So we are going towards the carcinoma part. But if the markers are elevated, Dotonac PET CT is showing good uptake, then I don't think we need multiple biopsies.
Okay. So this patient got sandostatin as first line, and in 4 months we have an increase in some of the peritoneal deposits. So Mangesh, what is your next option of treatment for this patient?
So well, when the patient progresses on octreotide LAR, I would like to start the patient on everolimus, which I think is a combination that we like to use. So I would like to start on everolimus.
Okay. Do you do a repeat biopsy like which is like what is written in this slide here?
No, not routinely. The reason I say that is because I know the biopsy will only show you a higher grade, but you are still going to rely on everolimus. So at this stage, I might not do. Post everolimus and octreotide LAR, I would be definitely tempted to do.
So Dr. Amit, if there is no symptomatic progression, how frequently do you scan these patients?
Scan usually once in 4 to 6 months, sir. Usually we monitor with chromogranin A. If it is uptrending or patient is symptomatic, then only we go. Otherwise, 6 monthly only I do the scanning, sir.
So Nandish, if a patient has got a raised chromogranin,
Okay.
and that is, I mean, there is a like this patient, you can see the chromogranin has increased and the scan is also showing increase. Do you actually do scans, or a raised chromogranin itself is enough for you to consider a change of therapy?
Only raised chromogranin, I would not rely on changing the treatment, because there are many false positive reasons, and one of the false positive reason could have come intermittently in that patient.
Right.
Unless there is a very high drastic from few hundred to it has jumped to thousands. But still, my treatment only on chromogranin, I never change my treatment. I usually correlate with radiology, either a CT scan or if a pair this one Dotanex scan.
So if you see this slide, this patient has got non-DOTA avid liver lesions increased in the DOTA PET on April, right? And chromogranin elevated.
Yeah.
Do you confirm this with a PET CT now?
No, means you can see for an academic point, or for the work of completion, you can get it done. But the fund baseline report where it was showing grade 2 and a Ki 67 on a higher side of grade 15%.
Yes.
Looked like a tumor which required some sort of chemotherapy. Maybe some would have agreed upfront or some would have chosen later on. But
you would have gone for CAPTEM for this patient, right?
Now I would have definitely opted in this second setting, because the moment a PET CT is showing uptake in a neuroendocrine, it implies that it is a chemotherapy sensitive tumor. So if there is a lot of FDG uptake, I think, because that is not a marker, but it is an indirect marker that these things won't work.
Right. So, Dr. Rajiv, would you have done a PET CT to confirm that, okay, the non-dota-avid liver lesion now is showing FTG uptake, and then get a biopsy from this and see that, okay, the Ki 67 is now 23, or you would have changed treatment?
If you ask me, I usually do. On progression, we do PET scan and repeat biopsy also.
Okay.
Recently, we had one. Today morning also, I had a same patient. So low grade patchy uptake of Dotanac with increased uptake of PET. So CAPTEM doesn't work. So chemo platinum sensitive. The patient was sensitive for platinum. He responded for platinum. Cisplatin. EP we give, he does better with the EP rather
Since you
than
brought in
capecitabine
this
or temozolomide.
chemotherapy, my last, I think, last 2-3 minutes.
Yeah.
Regarding the IV
So
chemotherapy option, other than platinum and etoposide, what are the other chemotherapy options which all the panelists use? We'll start with Dr. Poonam.
Most commonly EP only I use.
Other than EP, what would you use?
And it's very.
So gemcitabine
Other
platinum.
than EP, I would go for paclitaxel carboplatin.
Paclitaxel, is it? Okay. Amit, you were saying something.
Gem
Yeah.
carbo, paclitaxel.
Gemcitabine platinum, sir.
Gem platinum. Dr. Rajiv?
Yeah, gemcitabine along with the platinum or paclitaxel with platinum, all those works.
Okay.
When there is a PET uptake is there.
Sir, if no one is saying Folfox, I'm bit
Right.
Folfox is one chemotherapy which has been recommended in all the grades. Even I think grade 1 in 4th line they have recommended after carboplatin etoposide. And grade 3 and neuroendocrine tumors, that's a carcinoma after etoposide they have suggested. That would have been a blanket, means it works in all of the things. And any thoughts on that?
Yeah, one thing from my side, Folfox, if you are used already capecitabine based therapy, whether to give it or not is one thing. Another thing, in our personal experience, so Folfox was not done well with these subsets.
Okay.
I don't know the reason, but they are not done. So that's why we changed into Paclicarbo and Gem Carbo. They are doing it better than this Folfox.
This Gem Carbo thing is, there is not much of evidence to support it, but
Yes, I agree with that. I agree with
that. So I think we will stop here. We have realized that there are different treatment modalities which are available, and wise use of modalities help us in taking our patients ahead, and keeping the quality of life of the patient intact is also vital in diseases like this, where we all will have a few patients who are doing so well on all these therapies, except the situation when they reach cisplatin etoposide, and there actually once you progress, you don't have too many options. So I thank the organizers, I thank the panelists for a wonderful interactive session, and back to the organizers. Thank you.
Thank you so much, Prasad sir, and all the panelists for a wonderful case presentation and the interaction. Now, since we have Dr. Suresh Babu sir, Dr. Suresh Babu sir now, sir, can we have a concluding session?
I think thank to both Prasad and Rajiv, also all panelists. I think we did come to some conclusion. There are some things which we about the imaging and all but there is a clarity of neuroendocrine tumors what it used to be. One of the things which we have to keep in mind that nuclear medicine is coming up, as one of the discussion was happening. Nuclear medicine people were a little bit hesitant before. Now they want to give upfront for every cases. If you say they, no, we will try to do that like this. So, in fact, nuclear medicine HOD from Kidwai wanted to join this. I didn't join. So I think end of the day, multi-tumor and tumor board will answer how are we going to treat any patient should be kept in the tumor. So I think the neuroendocrine tumors people are going to survive longer. The confusion starts off the second half, but we'll get that. Thank you.
Thank you so much,
Thank you,
sir.
sir.
Over to you, Saurav, for the vote of
Yeah.
thanks.
Thank you, Anjana. Thank you, Dr. Suresh Babu, sir. It was indeed a great discussions. Your speech as well as both the panel discussion was actually very interactive and interesting. A lot of clarity we have received. I believe the delegates, those are attending today, these sessions are get a lot of insight from you, all of your seniors, expertise, opinion. With that, I also very happy to tell you and announce that today the total number of delegates in this webinar was 180 across. So being in a physical meeting, 180 audience is very difficult to get. But yes, not only here, most of the webinar from our end, we used to get one more than 160 and one close to 200 delegates. So I believe with that, these meetings, the series of webinars will help all the senior, mid-senior, as well as our respected delegates to get nice insights and opinions, and as well as the real-time evidence-based informations from you regarding the disease basis. So with that, I'd like to thanks to the entire panel members, delegates, and faculty members. Thank you very much. Thank you to Mice Ideas, our backend team who is organizing this meeting. And also, I would like to thank you again, Dr. Suresh Babu sir, Dr. Rajiv sir, and Dr. Prasad sir, and also our panel members. Thank you. Have a nice night.
Thank you so much. Thank you.
Thank you so much, everyone. Thank you.